Good morning, everyone. We welcome you all to Ortho TV. This is the monthly MISSAB tutorials. And to introduce today's topic and the speakers, I hand over to the convener and the secretary of MISSAB, Dr. Arvind Kulkarni.
Thank you, Niraj. Thank you for streaming us live for the last 6 months. It has been a watershed point in the history of MISSAB. So we have finished 6 grand rounds in the last 6 months, and I'm very thankful to all the participants who contributed. As we move to the next set of 6 webinars, I thank Intas Pharma, especially Mr. Jagrup, for his kind help and sponsorship. So as I realize, this is the last MISSAB webinar of this year, and we'll be entering not only in next new year, but we'll also be jumping into the next decade. So, the motto of MISSAB has always been to encourage youngsters, because minimal access basically relates to learning new techniques, new technology, and who else but the youngsters who can absorb it. And they will be the flag bearers of this particular society in the future, of course, with blessings and guidance of veterans. So that is the pattern of involvement that we have today. So we have the Young Turks presentation should be reviewed and guided by the veterans in those techniques. And we also have a great lecture coming, which is very, very important when it comes to patient counseling. That will be Dr. Balamurli. So without wasting any time, I would like to hand over the baton to Dr. Niraj Vasavada, who will be the commanding officer today. Niraj. Thank you.
Good morning, everybody. Thank you, Arvind. Thank you, Niraj, for wonderful technical support. So as Arvind said, today we are mainly going to focus more on minimal invasive technique, the surgical technique aspects. So we have a range of techniques to be presented today, right from endoscopy to all kind of minimal invasive stuff. And we have very experienced young speakers to present their work. And we have doyens of minimal invasive surgery as panelists to answer any questions we have and share their experience. So before I introduce my speakers, let me just give a brief introduction for today's panelists. So first and foremost, we have Dr. Anand Naik from Delhi. Everybody knows that he's a big man for interior and NT-SUAS surgeries, as well as all kind of minimal invasive surgery. Ranjit, evergreen all-rounder, big man from South India. I think, it doesn't require an introduction. Dr. Bhanot, probably one of the few pioneers in transforaminal endoscopy and cervical endoscopic surgery. We have Dr. Monu Singh, who is also a very experienced endoscopic surgeon. Dr. Rakesh Lohana, a neurosurgeon who is very much keen and interested into every kind of minimal invasive surgery, and he has a very huge experience with posterior cervical minimal invasive and thoracic minimal invasive surgery. We have 2 young guys who are going to present the review journal article, Dr. Poorana from Pune and Dr. Rajendra from Mumbai. We have one of the very experienced neurosurgical faculty, Dr. Balamurli, who is our guest lecturer today and is going to present today on timing of surgery. Does that has any implication on outcome in degenerative lumbar disease? Then the surgical technique will be presented by young experienced surgeons, starting from Ayush Sharma, Dr. Ketan Deshpande, Dr. Ashish Tomar, and Dr. Mukul Kaushal. So we are trying to cater entire country. Each corner of the country is represented today in minimal invasive surgery. So without wasting much time, I think, first we will start with our journal club. And may I invite Dr. Poorana to share his screen. Dr. Poorana is going to present his technique on endoscopic surgery. Over to Dr. Poorana.
Good morning, sir. Good morning, everyone. Myself, Dr. Poorana, FNB Spine Fellow from Pune, Dinanath Mangeshkar Hospital. So warm regards from DMH Pune. So today's journal club article is basically a new full endoscopic technique for cervical posterior foraminectomy in the treatment of lateral disc herniation using a 6.9 mm endoscope. It is a prospective 2-year study of 87 patients. This is one of its kind because this is the first prospective study which follows the patients for 2 years. So this is basically an original article. It can be said as a landmark article because it is one of its kind which first goes into the depths of this posterior cervical foraminotomy, that is endoscopic. So it is by Rutten from Germany, Rutten et al. From Germany, in a minimally invasive neurosurgery journal. So to start with cervical disc herniations, the topographic anatomy and their description was first done in 1940s. So during the same period, posterior surgical access to cervical spine was developed. But anterior access gained importance in 1950s, and now ACDF is considered to be the standard for cervical radiculopathies. So the objective of their study is to examine the technical possibilities of full endoscopic posterior foraminotomy in treatment of cervical lateral disc herniation with radicular symptoms. And their focus is on, they are questioning themselves, whether is there a sufficient decompression? Is there a possible effect of reduced traumatization? Is there any specific possible complications during this procedure? And how to access the technicality? And this is a prospective study. So coming to the materials and methods which they have used during their study in 2007. So regarding the patient characteristics, they have selected initially 100 patients with 61 and 39 made. Their study time is from 2003 to 2005 and mean age is 44 years and mean symptom complex is 29 days. Nearly 13 patients have been operated in the first day because of unrelenting pain. So 81 have undergone conservative therapy and remaining 19 have been directly operated, C5-6 being the most commonly operated level, followed by C4-5, C6-7 and C3-4. So their inclusion criteria is unilateral radiculopathy with arm pain, which should be contemplated by the MRI and CT correlation, and the segment they have selected is from C23 to C7T1. Any craniocaudal migration of the disc is not considered as an exclusion criteria. And secondary foraminal stenosis have also been included in their study. So their main exclusion criteria being, if the disc herniation is a medially localized herniation, then it is definitely contraindicated and with clear-cut instabilities and deformities. Isolated neck pain or foraminal stenosis without any disc herniation seen in MRI were not included in the study. So what is the operative technique? So all the patients have been operated under GA and patient in prone position and basic delordosating the cervical spine has been done and head is fixed with a tape. No special clamps have been used and arms have been positioned caudally as we do for our posterior laminectomy approaches. So first they do a postero-anterior X-ray where they identify the line of spinal joints, which is basically 2 centimeters from the midline. Once they have identified this PA view X-ray, their entire surgery proceeded with lateral imaging control. So the procedure is basically to determine the segment as such and make a stab skin incision. An insertion of the dilator, which is basically outer diameter of 6.9 mm, followed by insertion of sheath over the dilator, which is a 7.9 mm outer diameter. Remove the dilator, insert the optic with continuous irrigation, and then on the surgery proceeded with visualization, direct visualization. So first to start with, prepare the facet joint and flavum ligament. Start with bone resection at the medial end of the joint, then resect the lateral flavum, identify the cervical myelin. Since cervical myelin cannot be retracted much, we have to start with the lateral bone resection. So the hemostasis, they have used RF coagulation and continuous irrigation also prevented them from having much bleeding. Mobilize the nerve, extend the foraminotomy and resect the segments. Depending upon the migration of the disc, whether craniocaudal or something, they have extended their foraminotomies also. So their thing is post-operatively, all the patients have been put on 7 days of soft cervical collar. No analgesics have been prescribed thereafter. Regarding the instrument specification, it is basically from Richard Wolf, rod lens optic of outer diameter 6.9 and optic of intra-endoscopic eccentric working channel with a diameter of 4.2. Angle of vision is 25 degrees and sheath has an outer diameter of 7.9 mm. So what is their follow-up strategy? So they have followed up patients on day 1, 3 months, 6, 12 and 24 months. At the end of 24 months, they have done MRI for all the patients who were there in the follow-up period. They have sent a questionnaire by mail 4 working days prior to their visit And these patients are examined individually by 2 doctors who are not involved in the surgical procedure. Statistical analysis, they have used Mann-Whitney test and Wilcoxon ranked some test, and McNemer also, and SPSS they have used as a thing. And confidence interval they have mentioned is less than 0.05. So coming to the results of their study. So after 2 years, in a period of 2003 to 7, they have included 100 patients, among which they have followed up only 87 patients, because 13 patients, among the 13 patients, 8 patients have lost their follow-up and 2 patients underwent ACDF. So intraoperatively, they have analyzed for all these patients. In 100 patients, they have analyzed. In 87 patients, they have fresh nucleus tissue found. And in 13 patients, only bulging annulus without any fresh nuclear tissue. And the mean operation time is 27 minutes. And the technique is feasible in all patients without conversion to ACDF or any other procedure, open procedure, midway between the surgery. So no blood loss because of that RF coagulation and continuous irrigation. At the end of the surgery, they have measured the volume of fluid also inside the intracorporeal area. That is found to be only 15 ml. So perioperative complete, they have not encountered any serious complications, and they have not abandoned surgery in any of the patients. So 3 patients had transient dermatome related symptom, which subsided in a period of days. So 3 patients, they have 5 recurrences. Among these 5 recurrences, 3 patients have been operated again with same technique, and 2 patients underwent conventional ACDF, which they have removed from the study group. Regarding the radiological findings, at the end of 2 years, they have done an MRI. Regarding the radiological finding, this is very important. They have not found any new damage to adjacent discs, which is the main prime importance in our study. And 9 patients, they have adjacent segment degeneration, which is worsening, but it was already pre-existing. No sign of increasing kyphosis or instability. In 28 patients, they have shown advanced degeneration, but that doesn't alter their clinical outcome. Regarding the clinical outcome, no operation-related pain medication has been given. Mobilization has been started immediately. There is a constant and significant loss in pain in arm and neck over a period of 24 months, which we can see with this VAS for arm and neck. And also the clinical outcome, you can see out of 87 patients, 76 patients have a excellent outcome, where you can see it over here over a period of 24 months. So coming to the discussion, so what they have discussed is, so our primary standard procedure for any cervical lateral disc herniation or a medial disc herniation is ACDF now. But what are all the limitations for ACDF? Some access complication. There is a chance of pseudoarthrosis, loss of disc height, and also the main prime importance, we are just going to fuse that motion segment, which may lead to loss of motion at that area and adjacent segment degeneration. So what is the problem with the conventional open posterior forearm anatomy? Intraoperative bleeding is the main concern, and also postoperative neck pain because of so much of muscle dissection. These 2 limitations have been overcome by their study of endoscopic forearm anatomy, where they have encountered less bleeding. It is a motion preserving surgery. We are not going to fuse anything. And it is a direct decompression because we are accessing the disc directly and removing it. And there is no issue with the revision if at all needed also. And the main thing is we are directly visualizing a good anatomical presentation and less traumatization. And the patient acceptance is also very high. So what is the conclusion of their study? The main thing is, whatever endoscopic or minimally invasive technique which we are talking about now, surgeon first should have mastered about open and maximally invasive procedure first, before going into or venturing into a minimally invasive technique. It is not a replacement, but always a safe alternative for motion preserving surgery. It has got a very high learning curve. And these groups, they have again done a prospective randomized study after 2007, that is in 2008. That is a randomized control study, which they have included 100 patients. And this is the second one, which I'm showing here, is a recent article of meta-analysis, which they have compared posterior cervical forearm anatomy minimally invasive versus anterior cervical discectomy and fusion. And these are the 14 studies included in their meta-analysis. And at the end of meta-analysis, they have concluded this thing. that is minimally invasive foraminectomy. It found to have a significantly greater improvement in VAS arm scores compared to ACDF. That is a point to be noted actually. There were no differences in complication on reoperative proportions. That is also a main thing. Both are a very good procedure if at all used for a specific indication. But the most common complication being temporary neuropraxia or wound related complication. So it is a safe procedure and an effective alternative to ACDF. If at all, there is a unilateral cervical radiculopathy without any myelopathy and the disc is laterally localized. So thank you so much for your kind patience for listening to this talk. I thank my teacher, Dr. Pairaiturkar Pradyumna, for guiding me in this talk. Thank you.
Excellent, Dr. Poorana. That has been a comprehensive review. Now I think, we'll take 5 minutes for discussion, and I think I'll open the session to all panelists with 2 questions. First, there was an exclusion of foraminal stenosis without disc. Any particular reason for that? Any of the panelists? And then I would want to ask specific questions to 3 panelists. Ranjit, any difference do you feel with tubular and this endoscopy? Dr. Banod, what is the specific advantage of this endoscopy and your experience? And Dr. Monu, how do you deal with dust and dew? Any specific difference on dust and dew in this foraminectomy? So I think, first question is why we have to exclude isolated foraminal stenosis. Rakesh bhai, would you want to venture into that?
So basically, whenever there is isolated foraminal stenosis because of disc collapse, then ACDF would score over this because it will jack up disc height. This would be reserved predominantly for a soft disc herniation, soft foraminal disc herniation.
Okay. So I think, the message is that if you have a collapsed disc, in some of the cases, you still can do a posterior foraminectomy. But if you really want to jack up the height of foramen, because if it is stenosis because of this loss of height, then ACDF would proceed over the posterior foraminectomy. Now, second question, Ranjit, tubular and endoscopy.
Yeah, Niraj, when you do an endoscopy, you have the site of vision at the tip of your endoscope, that is at the site of the pathology. When we're doing, we know that the optics of endoscopy is anytime better than the optics of a microscopy. So definitely, and the mobility enabled by an endoscope is much more than the mobility we can have with a microscope. So I feel that this is the epitome of the procedure, but definitely there's a learning curve.
Right. Arun, challenges while doing this posterior foraminectomy.
So
apart from learning curve is okay, and I think that has been well talked about.
Yes. So as Ranjit already said, in the learning curve of all endoscopic procedures for the full endoscopic technique, cervical endoscopy comes at the top. So that means people who are not well versed with use of the endoscope in the lumbar spine first should not attempt it, because it's a very, very risky procedure if they're not familiar with the use of the instruments. 2, there are 3-4 things which are very important for performing the cervical endoscopy. One is when you are introducing your blunt obturator, I personally recommend that your stab incision should go right up to the deep fascia sheath, and it is to be done under lateral fluoroscopic control. So that will allow a very easy, smooth insertion of the blunt obturator, so that you do not plunge with your obturator down, and because in front is a cervical spinal cord, so you do not have any luxury of injuring any structure here. 2, it is important to dock the cannula onto the facet first rather than in the intervertebral, in the interlaminar space. 3rd is sometimes wrong level can happen because cervical discs are oriented very close to each other. So it is important that once you have docked your cannula and you, after clearing, you are going to drill, you again do a lateral fluoroscopy to just do a double check before you start drilling, because sometimes if you have shifted your entry point even by ½ centimeter in the skin, it can lead to a gliding of the cannula up or below and lead to a wrong level surgery despite you start with a fluoroscopic control. 3rd is the bleeding sometimes that can happen. Now, the best way to prevent bleeding in endoscopic surgery is to look for the vessels in the epidural fat and first coagulate them rather than you start picking on them. because once you have a bleeding, then it becomes very difficult, and you can't just explore and kind of coagulate them in cervical spine, because you do not have the luxury of going under the spinal cord. Fifth point, you said foraminal stenosis. If you remember, see the study parameters, actually foraminal stenosis is not a complete exclusion on its own. So a lot of foraminal stenosis which are causing radiculopathy from the posterior aspect can be comfortably treated, except for the one Dr. Rakesh just said, that if the symptoms are contributed by loss of disc height as well, then only it's not a good choice.
So Arun, there is one question from Amit Bhai, that what if you cannot see in lateral, especially C6, C7, which is so many times a case?
Yes, that's right. That's a very pertinent question. I forgot to enter. This is again another tip. As this particular study said, they don't use any kind of a Mayfield clamp, etc. In such cases, you can use a Gardner well or a Mayfield clamp to give a traction and give a counter traction on the arms, and then that can allow for a lateral visualization of the C6-7. So visualization of C6-7 in short necks is a problem. I have personally done one C7-T1 as well, which was not so easy. So we used AP view more and relied on, because of the first rib which was attached to the T1. So we took a guide from that. Otherwise, it's not easy to visualize on the lateral view.
Any difference in endoscope, Arun?
In endoscope means?
As compared to lumbar?
Oh, so the cervical endoscope is smaller in diameter, but the size of the length of the endoscope is similar to the interlaminar endoscope, whereas transforaminal endoscope is longer. The interlaminar and the cervical endoscopes are similar in length.
Okay. One quick question from Rakesh Bhai, and then we'll go to Dr. Monu Singh.
Two things that was very important to note here, like post-operative no analgesics used, and there was hardly any blood loss intraoperatively. So Dr. Bhano, this is the same experience with your endoscopy as well? That is surprising. Cervical, it would bleed at times.
As far as painkillers, analgesics need, it is absolutely similar. But in my early cases of cervical endoscopy, I have encountered a couple of cases where I did explore in the foraminal space and encountered a bleeding, which it took me some time to control. So in those cases, we might have had a loss of about 30, 40 or 50 ml, because it's difficult to measure as it continuously gets irrigated. So, but that is the trouble of visualization, not the amount of blood loss in any case.
Okay.
And
so
one more thing. If you are having a lateral foraminal stenosis, which is extending beyond the 50% of the facet or the foraminal width, then in that case, it has to be done very carefully, because the more lateral you go, the more anterior you will have to go. And as we know, more anterior is the vertebral artery. So one should not venture into that zone. And if it does, you have to be very, very careful about protecting that.
Okay. So the next question is to Dr. Monu Singh. How about Deshpande? Easier, harder? What's your take on that?
Well, I am very clear about this. Any procedure, for it to be effective and safe, there are two things which are very important. One is the maneuverability of your instruments, the access that your instrumentation should be able to provide. And second, obviously, is the visualization. So if you are able to see clearly, and that is where most of the systems with smaller cannulas and fluid medium irrigation, they score over Deshpande here. And we are also talking about the footprint of the instrument, which is beginning to get smaller and smaller. So those are advantages, and they have definitely come in from the initial generation of instrumentation, which used to be an endoscope in a tube. Now we are going closer and closer towards an endoscope, which itself is probably the tube. So I think it's an evolution of technique which is happening here, and it is bound to provide definite advantages. As Arun has very clearly told us, that there are situations where one has to be absolutely sure of where we are, intervening. And there I feel visualization is the key, because you are able to operate as safely as possible only if you are able to see as clearly. So that is definitely advantage of the evolving techniques with the fluid medium and the smaller trocar and the footprints of the instrument. And obviously, the smaller the footprint is, the better it is for us to maneuver inside the limited space that we have. So definitely, yes, it's an advantage now over a Deshpande, I would say.
Okay, so I think with the short of time, we'll go to the next talk. I think before we take the next paper, Bala has to go for some other talk. So we will have to take Dr. Bala's talk first. So Dr. Bala, are you there?
Yes, I'm here.
Okay. So over to you, Dr. Bala.
Hi. Hello. Good morning, everybody. It's a lovely morning out there on Sunday in Chennai. I'm Dr. Balamurali. I'm talking to you from Chennai. We've had a bad storm here and we are recovering. It's been a very difficult year, 2020, and I've also been given a very difficult topic to end the year. So does timing of surgery have implication on outcome in degenerative lumbar disease? This is probably the commonest question that we ask day in and day out, as almost 70 to 80% of our practice revolves around this as a spine surgeon. So let me see if I can make some justice. I may not be able to cover every aspect of the degenerative lumbar disease, but since we have a lot of young Turks, we will discuss about the most commonest things and how you decide on that. So degenerative lumbar disease is a progressive degenerative disease with aging and with various other reasons. So you get lumbar canal stenosis, you get degenerative spondylolisthesis. Later on, it slowly develops into an scoliosis and various other problems that we can develop. So the most important thing is the end result of degeneration. What is the end result of degeneration? So the end result is really a disc protrusion. The disc degenerates. Then your ligamentum flavum hypertrophies, the facets hypertrophy, they buckle. The disc height reduces, and then you start developing spondylolisthesis and lysis, and then you start developing a degenerative scoliosis. So this is the process in which it slowly, gradually happens. And eventually, as you grow older, you end up with osteoporosis, and which adds to the problem and the comorbidities of the patient. So the decision-making really is something very difficult. And as you get experience, you look at the whole thing, which you thought about when you were in your 20s, different in your 30s, 40s, 50s, 60s. So with experience, you tend to learn more. The reasons are being the natural history. Not all patients with narrowing develop symptoms. We've seen that. We've seen horrible scans, but the patient's absolutely fine. At the same time, we've seen, reasonably a good spine, whereas the patient is very symptomatic. And also there is no clear symptoms between the AP diameter, the size of the facet, how much of the ligamentum is buckling. And sometimes you find there is, on a static MRI scan, the compression is more on the left side, whereas the symptoms are more on the right side. So 20% worsen, 40% stay the same, and about 40% of them improve. Most commonest symptom being back pain, along with claudication pain, and then sensory motor disturbances. How common is it? After 40, yes, it is very common. About 1.7 to 2.2% of the population. As you grow older, about 60 to 70, it goes up by about nearly 47%. Patient selection is the key to your success. So the difficulties are, predominantly it is due to the degenerative changes in elderly. Physical examination is almost normal in the majority of them. MRI scan are very non-specific. X-rays may add information, they may not add information. The extent of stenosis is poorly correlated with their symptoms. Nerve conduction studies and other tests may not help. Your differential diagnosis can be very confusing. And you have to rule out all other conditions of other neurological conditions if in case you are not clear. The treatment plan and the strategy is based on the severity of the clinical symptom, the type of stenosis, the extent of stenosis, any instability, deformity. So all these things you have to consider whether you want to do an open surgery or a minimally invasive surgery, anterior approach or a posterior approach, a number of levels of fusion. So all these things are a very complex decision. So let's just talk about conservative as surgery, because it's very important to understand why you want to do conservative surgery before you think about why you want to do surgery. So it's both either physical or medical. So the physical is, physiotherapy and various other things, and medical is injections and various other treatments. We're not going to go into too much of details of that, but very important to understand what are the goals. If you have somebody on a conservative management, when do you decide to operate? So what are your goals of surgery? Pain relief, increased mobility, prevention of neurological deficit. And nowhere here you're going to see we have ever mentioned or talked about the radiological features, whether it's a grade 1 listhesis or a grade 2 listhesis or the amount of degeneration, amount of scoliosis. Patients with severe degenerative scoliosis are doing absolutely fine and you'd rather not touch them. The patient factors, if you look at it, in Indian scenario, patients, they want to wait till the end. It's unlike in the Western world where patients, want early intervention to improve their quality of life. In our Indian setup, patients, they want to wait till the end. They have fear of surgery, cost, lack of awareness, comorbidities. The Google doctor and the family doctor, the relatives who tell, do not let anybody touch your spine. From the surgeon's point of view as well, you always want to wait. As you grow older, we become more conservative. We learn from our experience that what may work and may not work. When you're young, you want to jump in very quickly. So again, the conservative trial, there's no clear consensus in the literature. What is a conservative trial? What do you put the patient through? Most of us surgeons are not very interested in managing a patient who does not want surgery. You tell, go see a physiotherapist and you forget about them. Whereas we don't put them through a proper conservative trial. Patient optimization, what is it optimization you do? A lot of dilemmas, a lot of confusion in the literature. And it also depends on what you're trained. Are you an anterior surgeon? You're trained in doing more of O lifts and A lifts, then you want to do more of that. If you're an endoscopic surgeon, you want to do more endoscopic. If you're a minimally invasive surgeon, you want to do. So it all comes from your background on your training, your teaching, what decision you take. So the surgery actually has to consider all these factors. Where is the problem? Is an entrance zone, is a mid zone, or an exit zone? So the surgery varies, the type of approach varies, and everything else varies. So the principles of surgery here, I'm not going to discuss about the type of surgery. If you have a spinal stenosis with a neurogenic claudication, you do a decompression. If you find this with instability or a listhesis, which is mobile, you do a fusion procedure. If you find all of these along with some kyphosis or scoliosis, then you also do a multi-level fusion with correction procedure. So the literature, what does it say comparing the two? So if you look at the main important studies, the main lumbar study, which looked at long-term patients, a prospective observational cohort study, that leg pain relief and greater back-related functional status continue to favor those initially receiving surgery. So they favored surgery. Now let's look at the sport trial. So this was one of the biggest trials which looked at the quality of life years. So they said that the good value of surgery compared with non-operative care over a 4-year period. So in the long term, though the surgical and non-surgical in a small subset remained the same, in majority at the end of 4 years, surgery was much better. Another study again, analyzing multiple meta-analysis of a randomized control trial, surgery groups showed better late clinical outcomes after 1 year and higher complication rates throughout the follow-up duration. So there was no significant difference compared to conservative group in the first 6 months post-op, but later on there was an improvement. Another study of 10 years showed that the outcome was most favorable for surgery. Treatment results of delayed surgery was essential, similar to the kind in initial group. And again, more studies which say surgery led to better results in pain. So I'm looking here at more of randomized trials, systemic reviews, type 1, grade 1, and grade 2 evidence. Cochrane review, in most times it says nothing is clear because it's an observation of multiple studies and they found that there was no clear benefit. So just analyzing the literature, most of the studies are in favor of surgical management. So this is when you have a dilemma, whether this patient needs surgery or conservative management, and there is a clear indication, remembering the goals that I mentioned earlier, why you want to do surgery. And remember, there's no radiological involvement in this. So the good prognosis were in disc herniation, in stenosis, single level, weakness less than 6 weeks duration, monoradiculopathy, younger age. Poorer prognosis in obese patients, scoliosis, say psychologically affected patients, cardiovascular disease, and all of the other patients. Now, the next question is, how early do you, okay, you've decided to operate, okay, the patient says, oh, I want to wait longer. So does the duration of symptoms in patients with spinal stenosis affect the outcome? So yes, patients with spinal with greater than 12 months of symptoms have less improvement relative to those with under 12 months. So they're all looking at anything between 3 months, 6 months, and 1 year. So most of the papers discuss in this range. So the timing of surgery and the symptom resolution, patients undergoing transforaminal lumbar interbody fusion for degenerative disease. The conclusion is a shorter duration of symptoms was found to be statistically a significant predictor of better outcomes. So this was a comparison of surgery before and after for about 2 years. A similar study looking at the timing, operation within 1 year had a higher rate of and lower medical costs and lower cost of accuracy. So in 3 years, they found that surgery was beneficial. And more studies saying that, patient undergoing a lumbar discectomy earlier on are generally associated with better improvements. So the commonest problem that I'm going to take now is a few literature reviews on discectomy. When do you do a discectomy? Immediate versus delayed surgery. So immediate surgery should be the primary option in majority of the papers. Comparative study of 1,192 patients, increased symptom duration due to lumbar disc herniation is related to worse outcomes. So earlier surgery again. This is the SPORT trial, which looked at is a multicentric trial. And the next is the effect of surgical outcomes. Patients with less than 60 days of conservative treatment had a better quality of life than the other group. Again, delayed surgery after failed conservative treatment increases the treatment cost and adds to the physical distress. So people started looking also at the surgery of early versus delayed, mainly in terms of cost, because if you want your patient to be off work for 3 months, 6 months, recovering from problems, he's going to lose money. Similarly, duration of treatment and outcome, we're looking at early surgery again helps. Sciatica, early surgery doubled with speedy recovery of sciatica. Cost, again, early surgery was more cost effective. Delayed versus early surgery again was more cost effective. Predictors of conservative, if you see the predictors of success is less pain duration, if they have a positive SLR, so these were all recommendations. So with or without a neurological deficit, again, early surgery leads to better outcomes. Now let's look at very quickly why. Why do they say that early surgery is better than a delayed surgery? So what happens actually? So when you have a disc degeneration or circumferential tear, the first stage of dysfunction happens. And then you have synovial, the synovitis, hypermobility, and micro instability happens. Then you keep waiting for a little bit longer. Then you get to a stage of instability, where your disc height is reduced, the disc is resorbed, there's a capsular laxity, the spondylolisthesis begins, and the patient's symptoms starts becoming sciatica, nerve entrapment. You wait a little bit longer, then it becomes unstable. So the stability becomes a problem, osteophytes form, hypertrophy happens, then your surgery has to change from a simpler operation to a much more bigger operation sometimes. So the effects of neural compression is because of the vascular, the biochemical and electrophysiological, and the central sensitization. So these are all the reasons why the neural compression progresses. If you look at vascular, the compression causes, hypoxia to the nerve endings associated with free radical generation, and then it causes permanent nerve damage. So at the point where I've said reversible up to this stage, if you intervene at that point, then you probably can reverse their neurological deficit, their pain, and the pain becoming a chronic pain. Whereas physiological and claudication pain, they become arterial or a venous problem. The pathophysiology is because of the arterial and the venous problems, where you have the reduction in the blood flow to the cauda equina and congestion, which adds to the problem. So the biochemical is based on the duration of compression, progressive epidural fibrosis, perineural fibrosis, thinning of the myelin gradually worsens the problem. And even if you do surgery at that stage, you may not have recovery. So these changes over 1 month, 3 months, 6 months, you see there's a thickening of the dura mater, alteration of the blood-brain barrier and the blood-nerve barrier, decrease in the large myelin fibers, increase in the small fibers, and then endoneural fibrosis and Wallerian degeneration. So this becomes irreversible at this point. So that is why early surgery is very important, because the more you delay, you start developing neural fibrosis, Wallerian degeneration, and then even if you do an operation, the results are not going to be good. The same happens with electrophysiological. You have the static and the dynamic mechanisms, where because we are consistently moving, and also depends on the type of work, the job, the person is doing, again, the degeneration gets worse. This central sensitization is something that's not very well recognized by people, but basically what it is the sensation of pain is no longer coupled with the nociceptive acute stimulus and rather represents an abnormal state of central response. So the central response in the brain works very differently after a certain period of time. And central sensitization, there's a more chance of duration of primary pain is more than 3 months. That's why the definition of chronic pain also comes that, after really 3 months, you have pain. So there's indirect advantages to early surgery. They return to work, indirect expenses, depression. Usually unsuccessful surgery in about 40% is either due to not taking a proper clinical history and diagnosis, the anatomy not well understood, the surgical planning is not appropriate, the decompression is inadequate, fusion is not right, probably the post-op instability is still there. You've not decided whether you want to do multi-level, one level, comorbidities of the patient. So the questions that need answering every time is there a time window when we decide what the conservative treatment has failed? Is there a time beyond which the relative benefits of surgery diminishes? There are lots of caveats. The standard period of conservative treatment will not be ideal for every patient. You cannot fix that 6 weeks or 3 months for every patient. It varies from patient to patient based on their symptom, their lifestyle, their work, and their pain tolerance. Treatment should be tailored to individual patients. The other guidelines which are available, like NAS or various other guidelines, do not actually respect any standard of care or protocol. You cannot develop a standard protocol in these patients. In atypical cases, treatment falling outside these guidelines may be necessary. Guidelines should not be used as a sole reason for denial of treatment. Guidelines are not intended to expand or restrict a healthcare provider's scope of practice and ethical standards. So the optimization for surgery, nutrition, their hemoglobin status, their albumin, pulmonary function, and all of these things need to be really respected. So do spinal surgeons have, what do they do in real life? So this was a survey that's done by Dutch surgeons, and there was no consensus even there. Even in the Western world, despite all the literature, it was very randomly selected between 4 to 8 weeks, 8 to 12 weeks, or after 12 weeks. But they all avoided surgery within the first month. So in conclusion, timing of surgery should be decided on an individual basis, jointly with the surgeon and the patient, considering their clinical problems. Early surgical treatment may be an attractive option for the patient with debilitating pain who seek quick relief, or those who do not experience satisfactory improvement with conservative. Patient selection is the key, patient optimization, very important. And I think, with all these various talks and lectures, the appropriate surgery to do that patient, a patient can be skimmed in different ways. It can be an anterior procedure or a posterior, it doesn't matter as long as you address the problem. I thank our MISSAB, Arvind, and the entire team, the president, for giving this opportunity as a guest lecture. Thank you very much.
Thank you so much, Bala. It has been an exhaustive, very detailed talk. So, that brings to a question that we really don't know what are the ideal timing for surgery. So let us ask our panelists, what are their views on that. Let me bring Anand out of his slumber and ask him that how would he decide when he would operate on a patient of typical lumbar canal stenosis coming with neurogenic claudication.
So, like Bala rightly said, there is no time frame or anything. It's more or less dependent on the symptoms of the patient. If they are suffering, they want to be out of pain, and you know that there is no other choice, you offer them surgery. So there is no real time limit or a time frame to wait for a week,
So
a month.
what are the things that makes you offer a surgery to your patient?
One is because there is lack of predictability of future in terms of pain and in terms of mobility and in terms of function of the patient. So you offer both. You offer both treatment, and I let the patients choose. That is factor number one, letting the patient choose. And the second, when a surgeon decides based on the electrophysiological, based on the clinical picture, electrophysiological studies and all, then I decide. But no time frame.
Okay. Before I take Dr. Monu's question, Ranjit, I would want you to come in and tell me, if I am a patient and if I ask, you have offered me a surgery, and if I ask you that, how long can I wait?
So you saw the slide from Dr. Bala. It is 20, 40, 40. 40% worsen, 40% get better. So I'll ask you this: it's up to your pain tolerance. Unless you have the red flags, it's up to your pain tolerance. But too long, you will not get completely better. Even early, you will not get completely better. So I will keep a ballpark figure up to 6 to 8 weeks to 12 weeks. That's when you can take a call.
Okay. I'll come to, first let's take Dr. Monu Singh in, then we'll come to Dr. Arun.
I just have a single, maybe a point of observation or a single question to the panelists here, my colleagues. When we are talking about surgery, where we're talking about surgery for a stenotic condition, let us not forget that it itself signifies something which has been a process, which has been going on. And it is a process which is evolving also. There is not really a time limit to the pathophysiology of this condition itself. So when we ask the patient to undergo surgery, what is the preference that we are giving to? Are we giving the preference to the acuteness or the severity of the symptoms? Or we are thinking in terms of the functional abilities of the patient and how much we are going to be able to restore them? What should be Dr. Bala? What should be our personal criteria? Because as far as I am concerned, we are so many times in a stenotic patient, we are more concerned about the functional abilities of the patient itself. The pain for us generally takes a backseat unless it's an acute condition.
Yeah, so as I mentioned, there is not one factor on which you can decide, whether it is the pain alone or the duration or the time. So you have to look into multiple factors. As you said, yes, pain may be moderate, tolerable, but his functional outcome or his functional status may be very, very poor. He's not able to stand for 5 minutes or not able to walk even for 5 minutes. But his pain is reasonably tolerable, but when he walks, it aggravates. So yes, that's a definite indication. The other group is the pain may be intolerable at certain points of time in certain positions, but at the same time, they may be functional. He may be working, he may be going to work and coming back, he may be driving, but he cannot sit for more than half an hour, he cannot sleep in a certain position. So I think multiple factors are there. And it is something that, as I said, it has to be a discussion with the patient. Okay, if I do this surgery, this is what you will achieve. If I do this procedure, this is what you will achieve. If he agrees with you on that, then yes, you can offer him surgery. I mean, any other comments?
Okay, so I think that brings to me another question. Let me bring Dr. Arun in. If I am a patient and I ask you that how much relief should I expect from any of your procedure, whether you do it MIS, endoscopy. So am I going to be cured 100%, or what should I expect would be my residual symptoms?
So
if I get delayed in surgery.
Yeah. So I'll come to answer your question in just a few seconds. I wanted to add a small comment to what excellent talk Bala just delivered. In my practice, what I have seen is when we talk of the limit of conservative treatment, as he said, it is flexible. It cannot be a ballpark figure of 6 weeks of conservative. My observation has been that anybody who is going to improve with conservative treatment starts showing a good change in the first 2 weeks. If the patient says that I am 50%, 40% better in the first 2 weeks itself, I start telling them that you are likely to get better. And if they do not show that much change, usually I start sounding them that you probably are going to figure, and this is relevant to disc only. Now coming to stenosis, we know it is a irreversible phenomena. It is not something like a disc which will shrink on its own or get phagocytosed. So in stenosis, it is more of a patient who comes to you for a significant degree of symptoms, and if the symptoms are disabling, especially in terms of claudication, because pain is usually a less dominant feature in those patients, so they will need surgery. We tell them that you are going to need surgery sooner or later, sooner the better, because otherwise all the factors that Bala said of sensitizing the pain and other symptoms, they will become chronic and they'll become permanent. The benefit of the surgery will not be accrued. Now coming to answer your question that how much pain should I relief should I expect? I always tell that I expect more than 90% change in your symptoms if I take you for an intervention. That is my strict criteria for my own patients' interventions. If that is not achievable, I will usually think twice before offering surgery, because surgery is a big intervention for the patient. Anything less than 80% is usually not accepted by the patients. They keep on complaining later on.
Okay. Rakesh bhai, one question to you. Say, for example, the patient with cervical stenosis, does your opinion change on timing? Say, for example, with modified GOI of around 15, timing, importance of timing?
Timing is important in cervical as well. So if patient has got early myelopathy or radiculopathy, I would try to conserve for even longer period of time. Cervical radiculopathy do resolve even after 3 weeks, 6 weeks. So unless patient has very severe unbearable pain of radiculopathy, I would wait. In a myelopathy, early myelopathy, wait. Progressive myelopathy, intervene. So it depends at what level patient is and its progressive deterioration. At the same time, MRI picture would also be important. How much stenosis is that? What is the basic pathology? That is also important in decision making, basically.
Great. So I guess, message is very clear from all the panelists that it's the symptoms which are more important. Timing is important for probably, early relief and a better relief surgically. There is still jury out that what are the ideal cases or ideal indications, short indication for surgery, except progressive neural deficit and patient's demands. Patient demand is the key word here. With that, I guess we'll go to the next journal club paper from Dr. Rajendra from Mumbai. Dr. Rajendra, please share your screen.
My screen is seen, sir?
Yes, go ahead.
Good morning, everyone. I thank MISSAB for giving me opportunity to present. I'll be talking on surgical techniques, management of high-grade spondylolisthesis, including reduction techniques. High-grade spondylolisthesis, there are variable definitions, but the most accepted definition is cases with more than 50% displacement and meriting grade 3 and higher. More than 90% of the patients present with back pain, leg pain, hamstring tightness, neurological deficit, stress incontinence of urine. They also have significant spinopelvic malalignment if untreated, which can progress. The surgery is aimed to achieve pain relief, adequate neural decompression, correction of kyphosis when the conservative management fails. There are various techniques which have been prescribed right from 1969, Harrington rod distraction being tried, followed by Magrel's external fixation techniques, which helps in getting the displacement and the reduction. A combined anterior and posterior surgery has been performed for the high-grade listhesis, as well as Bolman's and reverse Bolman's techniques have been described. Also, the translation to the posterior instrumentation have also been described. Instrumentation with the posterior fusion with or without reduction have been also described with good success rates. Reduction of L4 to the sacrum with the sacrum to the L5 screw fixation, delta fixations have been noted in the literature. Translation, instrumentation with or without reduction have also been given good success. Coming to the pathomechanics of the high-grade listhesis, usually there is deficiency in the pars interaortic or facet or laminar dysplasia or spina bifida occulta. Elongation of the pars or the stress fractures leads to the instability at the lumbosacral junction, leading to the anterior translation of L5, which leaves changes in the alignment of the spine in relation to the pelvis. Alteration in the sagittal orientation gives sacro and pelvic misalignment. There will be change in the vector of the shear forces at the lumbosacral junction. These changes are the basis of the new classification called spinal deformity study group classification. For the high grades, it has been divided into balanced and unbalanced. And the balanced ones are the unbalanced ones are the retroverted ones are the patients with the high pelvic incidence because of the increase in the pelvic tilt. Patients cannot accommodate the associated high L5 incidence angle, leading to positive forward balance. Also, the unbalanced spine is the one where the C7 plumb line falls quite anterior to the femoral heads in the standing X-rays. The balanced spine is the one where the plumb line falls posterior or at the femoral heads. Also, the balanced ones have low pelvic incidence and the high sacral slope. Also, there are various techniques regarding in open, MIS, and mini open techniques. All the techniques are aimed to achieve the posterior retention band and anterior structural support. Coming to the controversies, Posa et al. In 2006 shown significant and better results with in situ fusion techniques only, but the only problem with the technique was the paper was there were only 22 patients, a small sample was included. Coming to the JBG's publication in 2015, it clearly shows that pseudoarthritis is significantly high with in situ, that is 17.8% compared to the 5.5% with the reduction and fusion techniques. Coming to the complications, patients with fused with in situ fusion have shown higher neurodeficit, as much as 6% incidence of cauda equina, as well as progression of the slip with in situ fusions. There is separate controversy regarding balanced and unbalanced. Marty and et al. Has shown patients with balanced pelvis may not need a fusion, reduction and fusion, while unbalanced ones will only need reduction and fusion. There is separate controversy which exists between open and MIS, while it has been shown clearly by the literature currently that the MIS techniques are good with lower estimated blood loss, shorter surgical time, and shorter hospital stay with less morbidity. Coming to the techniques, the open technique, patients are positioned prone, the hips are given maximum extension. Sometimes the elevation of the patient's lower extremities can go above the table, which will help in reducing the pelvic retroversion in patients with a mobile L5 segment. Usually midline exposure is done, elevating the paraspinal muscles as lateral as to the transverse process, which helps in visualization of the nerves. Nerve roots are decompressed bilaterally. It is always beneficial to keep the ligamentum flavum intact to prevent the dural leak because of the distorted anatomy. Subsequent preparation of the disc, and after that a sacral dome is removed, which will help or facilitate the reduction. The polyaxial screws, some have used the Shan's pins for helping the reduction. The pedicle screw insertion point of the sacrum are quite superior and lateral than usual in the high-grade lysis. The insertion point of alpha is often unreliable because of the distorted anatomy, and direct visualization will help after the removal of the posterior elements. Destruction is often performed with the blunt instruments as cogs, which will lever and open up the intervertebral disc space. Harrington rod techniques, as prescribed earlier, helps in reduction as well. All the techniques are either rods or plate, which will be contoured and will be given appropriate lumbar lordosis to get good lordosis at the end. Few surgeons have used sacral screws first to reduce over L5 by rod or plate, and the posterior generative force, which helps in getting the reduction. Coming to the minimally invasive techniques, in 2002, Foley et al. Came up with the MIS techniques, which has shown significant results in terms of postoperative morbidity, dural leaks and infection, less hospital stay, blood loss, recovery period, and patient satisfaction. Qureshi et al. Have described, as well as Rajkumar et al. Have described high-grade lysis in treated with MIS techniques. A 3 centimeter paramedian incision is taken about 4 to 5 centimeter midline. From the midline, a blunt dissection over facet is done. A MIS retractors are placed. A surgeon can use a loop or fiber optic microscope as per their comfort. Standard MIS facectomies are performed bilaterally because it will help in reduction. A discectomy is done in routine fashion. These are the rocking techniques described by Dr. Rajkumar et al., which will help in reduction of L5 over the sacrum with the help of the rocking technique. Either we do MIS or open interbody fusion is mandatory. Few prefer P-lift, few prefer T-lift, few prefer A-lift. The concern about fusion is the graft should not be under the tension. Now, coming to the author's proposed line of management, the opinion of the authors Wagner et al. Was to best facilitate the restoration of the biomechanics of the elongation, which will help in anatomic reduction of the deformity. Patient was kept in prone position on a Jackson table. L4 to the low lumbar line incision was taken. Routine incision was routine exposure was done till the lateral parts of the transverse process. Authors preferred gill laminectomy, which will remove the lamina as well as the surrounding soft tissue and help in exposing the nerves. Following the Gill's laminectomy, a thorough decompression of the nerves roots are done, specifically L5. When the nerve roots are distorted, a running AMGs was done to stimulate the nerve to ensure the adequate identification of the nerves, because during reduction, the nerve compromise or nerve injuries are possible. Authors preferred electrocauterization of the vessels, epidural vessels, before they are torn. Once the lumbosacral disc and the posterior cephalad portion of the sacrum has been exposed, a PLL is incised and excised. The disc material is removed and complete exposure of the sacral dome was done. The sacral dome osteotomy is as equal as the pedic subtraction osteotomy. The cut of the sacral dome is towards the anterior cortex of the sacrum and cephalad, which helps in further reduction. Following a discectomy, a copper elevator is put in the disc space, which will help as leverage to reduce the mobile segment. Continuous CM shoots were taken to see the reduction. This is the diagram showing the placement of the screws. The surgeons preferred doing instrumentation first and then decompression and discectomy, which will from point A to the point B, rod will help in reduction in this author's technique. Diagrammatic representation, again, a distraction maneuver using blunt instruments was done, which will give distraction and translation of the cephalad vertebra over the caudal vertebra. Final CM shoot was taken, showing a good lordosis, a good graft, and a good achievement of the reduction. As a routine practice, collagen material over the dura was put to decrease the adherence, and closure was done in layers. Coming to the complications, as discussed earlier, hemorrhage was tackled with electrocautery, and the few of the patients had neuropraxia in their study, but it is equivocal with the other studies like Harms et al. All authors received anatomic reduction, and pseudo arthrosis chances were pretty low. The post-op protocol of the patients was they gave KLSO brace or LS corset belt, and after 3 months, patients were started doing the routine activities. So coming to the conclusion, there is existent significant controversy, though the in situ fusion versus reduction techniques have given good results. Presenting our institutional study done at the Gabapin Institute by Dr. Vishal Peshetty are just showing the results. By MIS technique for high grade for mobile assesses, our own results were also equivocal with the other MIS techniques. Operative time was 144 minutes, blood loss was 102 ml, mobilization was done by same evening, hospital stay was 2.29 days. There was significant improvement in the VAS, back pain and leg pain scores, significant improvement in the SF36, significant improvement in the ODI scores. Radiologically, the foraminal height and the disc height and the sleep angle were improved, as well as the translation length was reduced, although there was no significant improvement in the pelvic incidence and other sagittal parameters. All the patients were achieved a breathable grade 1 fusion at the end of 2 years in our study. I thank you everyone, and I thank Dr. Vishal Peshetty, my mentor, for giving this opportunity to present the lecture. Thank you so much.
Thank you, Dr. Rajendra. Excellent talk, excellent review of the paper. Again, as usual, I would want to bring in the opening batsman, Dr. Ranjit. Ranjit, are you there?
Yeah, yes, very much.
Okay. So does this Lebele classification change the way you look at spondylolisthesis?
Yes, sir. Label A clearly mentioned, defined balanced and unbalanced ones. So they told if patient is having balance, then no need of reducing. You can fuse in situ. Even label classification being used by Risco, et al. And everyone, and they have found the equivocal result that if the balance values is there, you can fuse in situ. If unbalance is there, then definitely surgeon should go for the reduction and fusion techniques.
Okay, Ranjit, your views? Does
Yes,
it change
I-
your practice, the way you tackle your high-grade spondy?
Very much. Actually, it is the other way around what Raj mentioned. The balance, spinopelvic balance, was first described by Timothy Resco from Harvard General, which was taken up by the Labelle group. I strictly follow this balanced spine, balanced pelvis. In every unbalanced spine with unbalanced pelvis, I attempt reduction. With a balanced spine, balanced pelvis, I don't attempt reduction. I try in situ.
Okay. Anand, role of anterior surgery.
Oh, well, I do all any grade of listhesis anterior only. And if you can allow me, I can show you some x-rays which are there for ALF.
Okay.
Um,
So by the time you push in your x-rays, let me go
yeah,
to Arun.
Yeah, I think okay.
You have ready your x-rays?
No, I have to search. I think I will
Okay.
share them later with the
All right.
group.
Arun,
There are different.
Yeah, go ahead, Anand. Go ahead.
Yeah, so there are different techniques to reduce that. What you can do by anterior fusions, it's more biomechanically stable construct. If you go back to Raj, if you can go back to some of your slides,
Yes, sir.
in the introduction, you have shown the biomechanics,
Yes, sir.
the how the force is pushing the
Yes, sir.
vertebral body down,
Yes.
and the resultant vector is creating that vertebral body to slip all the way out.
Yes, sir.
Okay, so ALIF, the concept is you need the entire biomechanics is different from the posterior stuff. Okay, here whenever you use this approach, the moment you position the patient, you may or may not get the reduction. But the moment you sacrifice that ALL, the cut you make, you will see that the vertebral body will sink in. It will go all the way up to the back. And then what you have to do, you have to just gently lift it up. And in ALIF, have to be very careful because you can distract it up to 17 mm or 21 mm. So you really need to know where to stop. I ideally stop at around 13 mm or maybe up to 15 mm height, but very rarely 15 mm. 13 mm is good enough for me. Yeah. So in this slide, you can see the resultant force and all. So you are putting a spacer from beneath. You are having a good graft area for the fusion. But standalone ALIF, I don't recommend in any high-grade lithic listhesis. You have to stabilize them from behind.
Okay, Anand, see, the traditional teaching says that whenever you are trying to reduce or operate upon a high-grade listhesis, you are always worried about L5 root injury, while reduction. So what's your take while you are doing anterior?
So we never had any encountered any problem of L5 root injuries and all. It's basically simply distraction. You just have to distract the vertebral bodies and they will automatically reduce. So we never had any anything so far. I hope will not happen in future as well.
Okay. So Arun,
but in anterior, you need to be very careful about the blood vessels because there is a overhang. So you need to have a very good control of the iliac veins and iliac arteries. Just loop them out. And most of the time, when you distract, the vessels are kind of stuck in the front. So you have to dissect the vessels first, and then you can go ahead with the procedure.
Niraj, can I ask Anand a question?
Please.
Yeah,
you're the boss.
Do a lot of anteriors. Do you have any experience with Gaines procedure for high-grade listhesis?
No, I have not seen any Gaines procedure. I don't have any experience with that.
Okay. So have you done at least partial L5 corpectomy for a high-grade listhesis?
Never.
Never.
never needed because in ALIF you have got different shapes and sizes of cages, and you can get different. There is permutation and combination. You can mix and match the shape of the
Basically,
cages, or maybe
get
you can.
reduction. Make it more
Yeah,
pliable, get reduction.
yeah.
Okay. So Arun,
Yeah.
In a fixed high-grade spondy patients with in a balanced spine, balanced pelvis, any role of endoscopy for aminotomy or anything like that?
Only if the patient presents with pure radicular pain, which you can pinpoint to some narrow foramen and the perineural fat in that nerve root, in the vicinity of the nerve root, is significantly compromised, and you can do a trial nerve root block of that nerve, and if it gives a good yield, then you can consider it. I have done it just in 2 cases in all my 15 years plus of career, where I had just done an endoscopic decompression in grade 3 spondies, which were stable, just like you mentioned. And the rest of the cases I'd never consider.
Okay. Any challenges?
Usually not much, because you are focused on that. And nowadays, when your experience with the extraforaminal herniations by docking onto the facet, and you have the drill with you, it's not much of a problem to identify the nerve and then work around it. But I would like to add a simple comment and endorsing what Anand said. One, Gaines procedure, as Arvind asked, is mainly for spondyloptosis, not for high-grade spondies usually. And ALIF, you and me have trained at the same institute, and we know that they used to do a lot of ALIFs for high-grade spondy and not do any decompression from the back, and simply just do a percutaneous pedicle screw from the back. And we remember we didn't see any L5 root palsies. So that brings in the question of, is a thorough decompression of far lateral L5 root actually necessary when we are doing posterior surgeries alone?
Yeah, Anand. Anand, you need to unmute yourself.
So anterior
We are
surgeries are usually very, very good for such patients.
Yeah, anterior, you don't need any decompression because
I am
the
agreeing.
principle is indirect. But
Yeah.
whenever you're doing posterior surgery, you need to decompress the nerve. You need to see the nerve, then only you can jack it up.
I disagree with Anand. I have done all cases of my spondylolisthesis without making an attempt to look at the exiting nerve. It's only once that I had to go to the opposite side nerve root to decompress. It is all indirect decompression. I have never make an attempt.
I was told that you have to decompress.
Back also distraction,
because it is a dynamic compression. It is not static compression.
So can I just add something? Yeah. So if you get the height back before reducing, whether you do anterior, posterior, you won't have a problem. We have seen the nerve root coming right in our way when doing it high grade listhesis. The moment we got the height back, it just went back to its original position. So the trick, even we have some decent experience with doing high grade listhesis, MIS. The trick is to get the height back, whether you do it posterior or anterior before reducing. If you get the height back, the nerve root just relaxes. So before you reduce it, if you get the height back, whether you're doing anterior or posterior, it doesn't matter. That's what we have seen. So we have seen the nerve root just coming on the way, and the moment we got the height back, it went back and was relaxed. So even we have got the video of that. So that's just a comment to that.
Okay, so I'll go to Dr. Monu Singh. How much is enough in high-grade listhesis reduction? What's your take on that? Dr. Monu Singh, are you there?
Yeah, hi.
Yeah.
For me, it is for us, rather not for me, but for us, because we work as a unit, as a part of a senior colleague and spine surgeon. But what we have witnessed is we never try to force out a reduction. And as Anand has very rightly said, that in his anterior interventions, the spine tends to collapse on its own the moment the tethers are released. But mostly we are doing posterior intervention. So we realize that whenever we go in for a very thorough decompression, by the way, and we are always very particular about removing and visualizing and preserving the nerve, making sure that there is no damage to it. And reductions, particularly, we never try to force them. And whatever we are able to achieve with our particular manipulations after putting in the instrumentation, the hardware, we are happy with it. So long as the spine is stabilized, so long as the nerve roots are free, and obviously, as Ayush has mentioned, we do try to gain as much height as possible, as close to normal height as possible. But so far as the spine getting balanced, it is not always possible for us to get complete reductions. There have been situations in high-grade listhesis in old patients, especially in sometimes in patients with osteoporotic spine, where we are particularly careful because we have had instances of iatrogenic, injury to the bony tissues. So personally, I feel once we have gone in with the soft tissue decompression and clearance, and we've put in our hardware and we've tried to gently reduce it with whatever maneuvers, toggling or positioning or gentle, traction, everything. We never try to force it, and we never try to be very particular that we have to go in for a complete reduction.
All right. So I think message is very clear that, it is more important to align the spine to the pelvis and decompress the nerves rather than try to reduce to almost normal. So spinal pelvic alignment is more important. I think, we are running out of time. Otherwise, I would have wanted Dr. Rajkumar to come in, but I think we go to the next session before is about surgical technique. And I think we will have to change the sequence here as well because Ayush want to leave early. So may I invite Dr. Ayush to come up with his surgical technique.
So thank you for the invite, and good morning from Mumbai. So I will be showing our surgical technique of OLIF. This happened to be our 50th case, and we recorded it. So it's again something to show. So this was a 49-year male with presented with neurological claudication. You can see due to retrolisthesis, there is some amount of stenosis happening. And of course, he also had a back pain because if you look at there's a lytic listhesis with some vacuum sign happening. There was a scoliosis as well and a PILL mismatch of around 15-18 degree. So of course, like OLIF, we started with right lateral decubitus. The skin incision was standard, as you see. This is L3-4 level. So normally 2 finger breadth anterior. This is the cranial end. This is the caudal end. And we have just taken the skin incision. So this is our skin incision. One of the most beautiful thing about doing a OLIF, I feel personally, is the natural corridor you go through. So you'll see we'll cut only the skin, the fascia, and the disc, and rest everything either you are retracting or just splitting. So this is the skin we have cut, and this is the fascia over the external oblique. So normally the fascia of the external oblique is the thickest fascia you will see. So this and rest of them, depending upon patient, you might get a thick fascia. There might be just a flimsy layer. So we're just cutting the fascia over the external oblique, and as I do it, my assistant will simply retract it. Rest everything we are just splitting. So even if you don't remember the layers, you will see the change in direction that will tell you that you are going from one layer to the other. So this is the external oblique, and then we'll go to the internal oblique, and then comes the transversus abdominis. So as you can see, we're just simply splitting with a mosquito. And as we go, we see the layer and we split the layer. Sometimes that 1 or 2 layers could be quite confusing. They might be very thin, but if you carefully look at the direction of the muscles, that will allow you to understand where you are standing. And the next, of course, is transversus abdominis. And again, we'll do the same. We'll just splitting the muscles. And the last layer is the fascia transversalis, which could be a very, very thin, flimsy layer. So if you see, now I'm in the fascia transversalis. So I prefer breaking it with the finger because the moment you break in, you are in the retroperitoneal area. So you can just put the peritoneal content anteriorly. And then this is how, as you can see, this is a blind thing. So you rely on the feel of your finger to do that. And at the same time, you start feeling the psoas, which is a very big, bulky muscle, as we know, and you cannot miss it. So exactly the same thing we are doing. So I'm palpating the psoas. We'll take a CM shoot out here just to confirm. And this is where I have changed slightly. Earlier, we used to do it with the under CM, put the guide wire and everything. Now I use this handheld retractors. So if you see these are specialized retractors, they're curved. So they'll simply slip over my fingers. So I am feeling that there's nothing, there's no artery. I have the tactile feel. And exactly where the finger is, I will let this retractor system slide. So we can see everything. So over a period of time, we started with slightly blind procedure, which what is the traditional teaching, you do it in the Siam. But now we do it everything under vision. So again, once I have put this retractor, the other one goes in. So we can see directly under vision before even we talk our first retractor. So that nothing is blind. Everything is under your vision. And so you can see the swas. Now, just to show you why this step is important, I have added a small video from a different level, which is the L4-5 level. So there is, so this is a different case. So as you can see, the swas is bulky here, and hopefully you can appreciate a cord-like structure coming here. This is a genitofemoral nerve. So this is, so it was just where we need to dock it. So if you are doing under vision, it is very easy to see everything. And if something like this is there, see how easy it is to just retract the whole thing. So because you're not using, you're using muscle relaxant, the muscles are relaxed, it is much easy to get the muscle and even anything out of the way. There are times when we have seen the aberrant artery or aberrant vein. But if you're doing under direct vision, all these things you can see, you can decide. So we just retract the muscle, see how easy it is. We have retracted it, and I will replace my handheld retractors. So the muscle, the psoas muscle, and the nerve simply goes out of my view. So I'm making sure before even I'm placing that nothing is there, and then we have again replaced the retractor. Now these retractors are like the same, like the blade of your of the tubular system. So they don't allow the peritoneum or anything to creep in because they are half circle retractors. We're using the simple retractor. Sometimes they might in. So even we are even the first dilator I'm putting under vision. So there's nothing which is beyond vision. Even while putting the other dilators, I can see the corners. So even something is coming on the corner, I can see. Once I have put the complete retractor system, that is the time I will remove my blades. And this is the, we just confirmed in the C-arm that we are in good position, anterior 1/3 of the body where we start. And this is my view when I'm starting. Again, this is the case we started with. And in between, I put a video just to show you why this step was important. And there are times when you get osteophyte, you need to remove them. So just removing the osteophyte. The rest of it is the standard, what everyone does. And then you use the disc shavers. This case was, this is completely collapsed. So we started with simple getting the disc height first, and then slowly working and taking out the disc. So we just have broken the opposite side, and then this we are just removing whatever the remnant of the disc is. And as we go, we'll start with the trial. So as you understand, you have to do the orthogonal maneuvers. That means I'm dropping my hand anteriorly while I do so. This is the orthogonal maneuver because you're in an oblique corridor and you want to be perpendicular to the disc at every time. And the C-arm shoot looks decent enough to finally place the cage. And now the cage is going in. So if you see this if you do it under vision, what we personally feel that over a period we have simply migrated from doing under C-arm with a neuromonitoring to doing everything under vision without any neuromonitoring. So last 1.5 years we have not used any new neuromonitoring, although we have it in-house, but still, and we never had a problem. We find it much safer, much happy doing this. And once I close the retractor system, everything simply falls into place. And that is the most beautiful part, I think, about doing this procedure, because you have gone through a natural corridor. And of course, you need to do the posterior MIS fixation. And just because the standalone could be risky in cases. So only thing in this particular case, we chose to do a single position lateral. So even the screws, we could safely place them in the lateral position. So that saved us the time of the flip, which we normally have to do. And we have been now doing few cases with single position lateral itself. And this is how finally it looks like. And so this is the indirect decompression. As you can see, the jacking up of the cord, the disc space has simply decompressed the cord behind, again, the serratal cuts. And even we could get a decent correction of the scoliosis and even the mismatch which we had. This is the final picture, if you can see. And if you look at the incision, we could just, this is the same patient, just a 2 centimeter incision. So we started somewhere in 2018, and these were the cases. This is my first case I started with. We started where we thought a OLIF can do something more than what a normal TLIF will do. So this was a revision surgery, a laminectomy done with focal kyphosis, with some amount of scoliosis. And so we thought that a single level, if you want to do and not venture into multi-level, OLIF could be the way. And this is what we could achieve with this case. Again, we could even get the decompression we wanted. And this is of course, this is the previous incision of the previous surgery of laminectomy, and this is what we could manage with. Now we have a 2-year follow-up, and patient had done very, very well. Again, another case, the starting case where we started, where these are the cases we started with, we thought where OLIF could give me more than what a TLIF could give. Again, a 60 female, a case of previous laminectomy, adjacent segment, you can see the instability, you can see there is a compression happening here. And she was very, very painful. Every step she was taking, she was wincing of pain because of instability happening. So again, we went with the OLIF. And in this case, we thought it's not that unstable, just adjacent segment degeneration. So we could manage with a cage and a plate, as you can see here, and a revision surgery in roughly 2 hours with a 20 ml blood loss. That is what you can achieve. And again, this is the intraoperative video. You can see the cage and the plate going through the same incision. And as you remove the whole retractor system, everything simply beautifully falls into place. And this is what we could get with her. Again, we have a 2-year follow-up with her, and she has done very, very well. So this is our own surgery. We have given her this laminectomy we did with this big incision, and a revision surgery with adjacent segment we could manage with just a 2.5 centimeter anti-incision. So this is her post-operative video. So my patient, where you do a standalone, the selected, they are very more happy the one you will fuse them posteriorly, because the corridor is very, very anatomical. It's the screw which hurts them. As we have gone ahead, now we have gone into doing some complicated things and doing a tool like this case with a degenerative scoliosis, a 2-level OLIF, and this is what finally we could achieve. And as we are moving ahead, this was again a patient with a previous laminectomy done, significant osteophytes on one side with a scoliosis of 31.1 degree, and this is a 3-level OLIF, one of our recent case, and this is what we could achieve. And if you see, there is a mismatch of 38.2 degree, and this is how we could, even with the cage itself, we could achieve a decent reduction. And you look at the thoracic alignment as well, the thoracic spine as well had just flung into this position the moment we got the lordosis back. So this has been our experience with OLIF. I just wanted to share some of the things we do. So thank you for your opportunity.
Thank you, Dr. Ayush. Wonderful presentation of a great technique. We are running short of time. So any burning comments from the panelists, please unmute yourself, or else we'll go to the next talk, because I've been asked by the boss, Dr. Arvind Kulkarni, to wind up before 10:30.
Just one question I have for Dr. Ayush. How often do you feel, are you always satisfied with the indirect decompression that you get with your OLIFs and restoring the disc height, or do you ever feel there is a need to supplement it with the posterior decompression ever?
So depend upon the cases. So if you see, if there's if there is the compression is not that great, and you are getting a good reduction intraoperatively, and is for one level for sure, what we'll do is we will just do a standalone and rely on the indirect decompression. But where it's a completely collapsed disc, and you know there is significant compression happening posteriorly, Our idea is to just do the cage, let the patient walk. And especially we do it when there are multiple levels, like the case I showed you, with that I showed you only the anterior part, because there are so many levels, there's so many, like you don't know what to decompress, what not to decompress. So we did the 3-level OLEF. We let her walk for 3 days. They're very comfortable. They'll walk the next day. Even after a 3-level, 3 to 4 hour procedure, they are so comfortable. You will be surprised how comfortable they are with the OLEF. It is the screw which hurts them, and they are crying, what did you do to me? So we let them walk 3 to 4 days in the hospital. If we see radiculopathy, if we see there is something happening, I get a MRI. In this particular case, he was getting a L5S1 S1 radiculopathy. So maybe the 3-level OLEF, what has done is there was L5S1. It has got compromised. So while doing posterior, I added a MIS TLF. So this is how our strategy has been. In cases we're pretty sure we'll go standalone. But if there is any doubt, there's no harm in doing a second stage, and you can do exactly what you want to be, exactly a simple decompression, or maybe add something more to it. That is how we have gone about it.
So a quick comment from Anand, and then I would request Ketan to be ready for his presentation.
So Ayush, beautifully done videos and all. You made it look so simple. Let me tell you, there are few caveats for Olive. I'm doing it for since 2011. I was part of the team with Pimenta and all. We started with diffuse synthesis. Now Olive has been marketing by Medtronic. Number one, you don't get a very good low doses. We talk about the low doses in Olives and all. They are straight cages. It's very difficult to get that. Number two, in early years, 2011 to 2014, we were doing standalone Olives, and we have seen more than 90% cages being subsided, maybe within 12 months, or maybe around close to 90% within 24 months. They subside. Until unless you get no matter whether you use BMP, bone graft, or whatever, they will always subside. And you always need to do the supplemental fixation. There is no doubt about that. Standalone ALF, you are taking risks. You are playing with the fire. Okay, so that's my comment. You have to fix that.
So
you have to fix it. You have to fix it.
Most of our cases, almost 90-95%, we do augment post for sure. Maybe a selected 1 or 2 where adjacent segment, maybe we have been lucky enough, and we have a few cases where we did a standalone with a plate, and we saw it, they were doing okay, but very, very selective, maybe 5% of our cases.
No, what height of cages you are using in Olive?
So depends. Depend upon the cage. The cages can be like from like 10 mm to up to 14 mm. We are using, and
how frequently you use more than 12 mm?
Not very frequent. Not very frequent. Depending on the patient. If there is a complete collapse, and see, I don't foresee. If you really want to do a very large case, as you understand, then you have to. And the posterior elements are completely arthropathy, and then you need to release it first, and even you need to release the ALL sometime, which gets very tricky. And that is where now I believe if you're doing everything in the single position, you have more ability to do back and front, and you can get more height. But it gets very, very complicated releasing the ALL, and then you go back again, release the posterior element just to get in more cages. So you can work posteriorly. You can just do a facet port. If we really want to get more lordosis out of single level, I'll use a maybe 12 mm cage with a 6-degree lordosis. Go posterior, do a facet release, and just compress it while doing the posterior work.
Excellent, Ayush. I think Anand, I think we'll have to move to the next talk, because otherwise Niraj will be calling us to. He has to go for another webinar. So we'll quickly jump to Dr. Ketan, and we go from one MIS to endoscopy now.
Thank you so much, sir. Due to short of time, I'll just jump into the topic. So the lecture is about the scope of unilateral biportal endoscopy. So as the name indicates, it's basically unilateral. So both the incisions are on the same side of the midline. Biportal, there are 2 incisions. So there are 2 ports. One is a scoping port and one is a working channel. So it looks something like this. So the yellow line here is indicating the midline or the line joining the spinous process. The red line, that's the perpendicular line, is the disc level. And the two incisions that are taken on the dotted blue line. The dotted blue line is basically an imaginary line just 1 centimeter lateral to the midline. And the two incision on either side of the disc level, one is the scopic portal and the second one is the working portal. This is how it works. So the scope comes in from one portal and the instruments, they come in from the other portal, and the flow of irrigation is from the scopic portal. It accumulates at the space where we are actually working and it comes out through the working portal. So the operative preparations are, we can do this either under general anesthesia or epidural anesthesia. The position is prone, same as that of microdiscectomy. We need to have a specialized drape which will have a fluid collection bag, and we need CM radiography for this. So this is how the patient is positioned, with the surgeon and the assistant standing on the left side, the CM coming in from the opposite side with the video trolley on one side and the image processing on the other side. So on one side you have the video trolley coming in, on the other side is the image process of the CM with the CM coming in between. The equipments that we need here are video trolley, scope that is either 0 degree, 12 degree, 15 or 30 degree with a trocar cannula and an irrigation channel. You need a shaver burr or a drill system. You need a good radio frequency cautery, some specialized UV instruments, and the rest are all general spine instruments. The operative steps are, we start with the skins portals, then we do the triangulation of these two portals, then we create a working space, and the rest of the procedure is similar to that of a tubular or a micro decompression. So let's just quickly jump into the technique and see what exactly we are doing here. So the patient is, it's a typical case of L4-5 central disc herniation with bilateral ligamentum flavum hypertrophy with lateral stenosis. So the patient is position prone. We mark the midline. Then we go and mark the working portal. That's usually the lower pedicle. Then we mark the scopic portal. That's approximately 2 to 3 centimeter towards the cranial aspect of the working portal. Once you mark these two portals, you take the CM into the lateral view. You put two markers on top of the points that you have already marked, and you take a lateral view. So here the yellow lines are the disc space. The black dotted line is the scopic portal, which is going to be bang on at the disc level. And the red dotted line is the imaginary line, which is showing the working channel the obliquity of the working channel. And the red dot at the anterior part is the point where these 2 points are going to meet. So on the ipsilateral side at the laminospinal junction. Then you take the incision of the working channel. You cut the fascia in line with the skin incision. You go obliquely, you check it on the CM that your tip is at the laminospinal junction of the upper level. You dilate the tract with these two dilators, and then you create the working space. So the superior lamina, the interlaminar space, and the inferior lamina. Again, the upper lamina, the interlaminar space, and the lower lamina. This is how you create the working space. That's it. Then you go on and take out those dilators. Then you take the second swab incision, which is for the scope to go inside. So this incision is slightly closer to the midline. It's smaller. Again, in the same line, you go down, cut the fascia as well. You insert the trocar. You make sure that you're touching the tip of these two instruments, and you confirm that on the CM as well, that you haven't changed the position. You're still at the spinolaminar junction, and those two instruments are touching each other. You do this kind of waddling movement wherein you create some space for the irrigation to get collected. You insert the sleeve, you attach the irrigation tubes, and your scope goes inside. So this is a regular arthroscope that we normally use. Once you go inside, there is some amount of soft tissue that will always come into your view. So you need to have a good radio frequency. That's the orientation. 9 o'clock is cranial, 3 o'clock is caudal, 12 o'clock is the medial, and 6 o'clock is the lateral view. So basically we are working on the upper lamina, and we need to find the point where the lamina meets the spinous process. So these two lines are very important. Yellow line is the spinous process, red line is the lamina, and orange line is the point where these two should meet. You again confirm that with the CM, and then the rest of the procedure is very similar to that of open procedure. So this is a different case wherein I'm showing how this thing is done. So you start by burring the upper lamina. You use radio frequency cautery to clear the soft tissue and visualize the bony edges. You go and drill the undersurface of the spinous process, And then you go and use your curettes to remove the superficial layer of the ligamentum flavum. After that, you go to the inferior lamina. You start working on the inferior lamina. Once you get to the lower margin, you detach the deeper layer of the flavum, similarly using a curette, and you take off that flava. Once you expose the dura and you retract the shoulder of the traversing root, you can find the disc which is lying there in the straight in front of you. When you wish to check, you can just literally go inside the epidural space, lift up the root, and you can still see that there are some fragments remaining there. You get them all out. You confirm it on the X-ray view where your position of the tip is. This was an inferiorly migrated disc, so need not go into the disc as well. We're just basically working on the posterior vertebral body of the lower vertebra. So this is when you have an ipsilateral approach for a single disc with a radicular symptoms. So when we have to go, so here the ligamentum flavum is intact. When you have to go over the top, you don't need to do anything else. You just need to burr extra the undersurface of the spinous process till you get this ligamentum flavum split, which is there in the midline. You identify that point as midline, confirm it on the C-arm. You do the ipsilateral flavectomy as we had already seen previously, and then you just go on going to the contralateral side. There is no need of tilting the table or changing the direction of your instruments or anything. We can easily go to the contralateral side. You got your scope is mobile, so you can go as inside as required. You go to the contralateral side, you do the lateral recess decompression. The irrigation pressure here is pressing the dura down and creating the line of separation and giving you a good space between the dura and the ligamentum flavum to work. You identify the contralateral edge of the dura. And this was a case where there was a right-sided herniation, still approached from the left side very easily, retracting the dura and the traversing nerve root, identifying the disc and just taking it out using forceps. So even if there is a disc herniation which is located on the contralateral side, even if it is down migrated, up migrated, can be very easily taken care using the same left-sided approach. If need be, you can go from the right side as well. You do RF radiofrequency ablation of the annulus. You check the adequacy of decompression. You pull the root. You can see both the axillary fat and the shoulder region, which you have already cleared. And that's the end point of the surgery. So this is about maybe disc herniation and central stenosis or lateral recess stenosis or a combination of all three. What about fusion? So with the same approach, what you do is you go a bit more laterally. You take off the facet and the rest of the steps are similar. So here I've already taken out the facet on the ipsilateral side. You can go in with your shavers with the same incision. You can go in with your shavers, do the discectomy, do the end plate preparation. These are all regular instruments. You don't need any other fancy instruments for this. You see that the end plates are bleeding beautifully. You go in and put your bone graft. You can go inside and check how much of good bone graft bed you have created. And then you just go in, just slightly increase the size of the incision of the working channel, and you can easily insert a big cage that's almost up to 12 mm in size with direct visualization while you're inserting the cage. And this is how the final picture looks like. So that's the C-arm view. And these are the skin incisions. So the same two incisions that were used for biportal endoscopy can be used for insertion of cage, and the same incisions are again used for insertion of percutaneous screws. So you don't need any other additional incisions. What about cervical? It's quite similar. We can do the same thing, posterior cervical laminoforaminotomy. Just in this case, we don't have to identify the midline. We have to be a bit more laterally where the overlapping of the lamina is and the facet joint is. So we have to just stay lateral. We have to identify the point where the ligamentum flavum is deficit. And from that point onwards, we can use a curette like this to enter into the epidural space. You separate the ligamentum flavum from the upper and the lower lamina. You use either a 1 mm or a 2 mm kerrison to cut it out. That's the root lying in front of you. So depending upon the location of the disc, you identify, in this case, it was a disc lying in the axilla of the root. So without any retraction, without touching the central cord, you can easily take out the disc, and the root is lying in front of you. The midline ligamentum flavum is intact, and that's the decompression. This was a 2-level case. So with the same incision, I need not come out and change the facial or the skin incision. I just kept on moving because the cervical laminae are so close to each other. I just kept on moving cranially using the same skin and the facial incisions. I was able to identify the upper level as well. So this is C5-6 and this is the lower level which we had already operated. You repeat the same steps on the upper level, and the 2-level cervical laminoforaminotomy can be done using same skin incisions. And that's the endpoint of the surgery here. So when we talk about the scope of UBE, so anything and everything that can be done through a tubular or microdiscectomy can be done via biportal endoscopy. So this is the incision of a single skin level. When we have to do 2-level in case of lumbar, we have to switch one channel to the other channel. So if we are operating at 5S1, 4, 5 and 5S1, we do 5S1 first, then the scopic channel is converted into working channel, and you take one or more incision on the cranial aspect, and with 3 incisions you can do a 2-level surgery. For a multi-level 3-level surgery, you go on increasing one more incision and you can do multi-level surgeries as well. Cervical also is possible to do with the same approach, and UBT-LIF also is possible to do with the same approach. If you only have a system like Sextant, you need those additional incisions for inserting the rods. That's the only difference. So what we are trying to achieve here is the versatility of the tubular decompression and the advantages of uniportal endoscopy. Combine them to give you a better visualization, medium which is fluid. So no, it's not an air medium surgery, but a fluid medium surgery. So you have all the indications of microdiscectomy, and you have the advantages of the eye being inside in the form of camera and the medium being water, giving you ease of bleeding control, good visualization. So the approach is easy. It's just initial triangulation that is different. So basically not a different technique, but just a different approach. You get better visualization and definitely much more broader indications than that of a uniportal approach. I thank you, MISSAB, for this opportunity.
Excellent video, excellent technique. So next speaker would be Ashish Tomar, and by the time he readies his screen, Dr. Arun, do you think that this is more versatile than our traditional interlaminar or a transforaminal thing, or any comment on learning curve on both of this?
So usually, if you talk about a single level pathology, especially a disc herniation, then the tubular full endoscopic technique still becomes the first preference. But when you talk about a stenosis or a multi-level decompression, then definitely UBE has a role. So if you want to go on to graduate to use UBE for multi-level or bilateral stenosis, of course, you will have to start with your treating these patients of disc herniation with this. So as a learning stage, you can use it for disc herniation, but I personally feel the overriding advantage of UBE is versatility of its application in fusion and multi-level stenosis, where it is quicker and faster than the full endoscopic technique.
Great. So I think it's a short of time. We'll directly jump to Dr. Ashish Tomar's video. Dr. Ashish, can you share your screen, please? Ashish, are you there?
Yeah, he was there. He was there till now.
Yeah, he still looks there, but I think he has some issue with maybe. So I think we'll go to the next video by the time he comes on. Okay, yeah, he's here. He is here. Ashish, you need to unmute yourself.
Can you listen to me now, sir?
Yes, you are audible.
Okay. Thank you for the opportunity. Good morning, everybody. I am here to speak on MIS-TLIF, and I'll be giving some video presentations. I think the most important step in MIS-TLIF is the facetectomy. So in this, we remove the inferior articular process and the superior articular process and do facetectomy. And I am a person who likes using osteotomes. So the inferior articular process is removed with the osteotome, and then the superior articular process is removed in this manner under the C-arm. I'll just like to share this procedure in detail. So this is how I do it. This is the inferior articular process that we are removing with the osteotome. Once we have docked the facet on the joint, on the center of the joint, and this is the superior articular process that is there. So once we have reached exposed the superior articular process, we mark it under the C arm. The facetectomy line should be right just above the pedicle. It should be right there, and we can use this. The osteotome can be used, and you don't need to go up till the disc. Just incomplete resection of the facet will remove the entire facet joint, and it can be taken out. And once it is taken out, it can be easily, this inferior articular process can be, the medial aspect of the facet joint can be removed, and slowly the entire facet joint can be removed. So this is just a demonstration of how a facetectomy, is done. So this is a complete, again, the same thing. The medial facetectomy this is the inferior articular process that is there. We are removing the inferior articular process here. This is again the superior articular process that is being removed. This is the disc. You can see this is basically the disc, and the ligamentum flavum is there. We slowly remove the ligamentum flavum and identify the traversing nerve root, and we can remove the disc. Then discectomy is done. Disc preparation is done on the ipsilateral side. In this, we are basically using a quadrant system, the self-retaining, expandable retractor system. Once the cage is put, the over-the-top decompression can be just done by tilting the table. So we have to tilt the table in a fixed tubular retractor system, which I'm going to show it in the other case that I'm going to present. So in that, you need to move the retracted system towards medially, and it is a better system because the muscle creep is much less with quadrant retractor system, and when expandable retractor system, the muscle creep is much more. But the benefit is that you can do corpectomies and bigger excisions anteriorly with these retractor system. So we are going over the top, and ligamentum flavum, one suggestion is to keep the ligamentum flavum till the end. It helps as a protecting barrier, and it prevents any injury to the nerve roots and dura. So this is just, doing the dissection. So this is once you have decompressed, and this is the vision that you get just by tilting the table. You can reach the over the top. The other aspect of the disc is there. You can do everything. The nerve root is decompressed both ipsilaterally and contralaterally. And this is the final picture with the exiting and traversing nerve root and the dura. So this is a case. This was a very, very interesting case. This gentleman had a 1.5 months history of foot drop. Seeing the MRI picture, if you see the L5S1, L4, L5 nerve root, L5S1 nerve root compression, it is there on the right side, but it is not like a very big compression. And this patient on neural examination, he had a sensory hyposthesia at L5S1. He had a foot drop. Rest of the neural examination was okay. Cervical spine, there was no radiating pain in the upper limb. There was back pain and radicular pain on the right side. This gentleman also had this is the cervical spine MRI. If you see, there is a cord change is present, but it is predominantly on the left side. And since the person was not having any, upper limb pain, or there was no myelopathic changes, the risk jerks were normal, every neural assessment otherwise was normal. It was just L5 and S1 looked to be involved. So we decided to go with, and do a TLIF at the L5S1 on the right side. So this is the basically the cage. This is the tube system in which it is fixed tube systems that we routinely use. So it again, this is the superior articular process that we are removing, and so I just wanted to show how you one is going to turn the use the how one is going to use over the top decompression, and how it is to be performed with these retractor systems. So we are doing discectomy on the ipsilateral side. You see that we are in the Cambin's zone. We'll just be seeing the exiting nerve root and the traversing nerve root. So this is the traversing nerve root that we can see. This is the exiting nerve root. We'll see it more clearly just in a few seconds. This is the case that we have put. The exiting nerve root has been retracted. That is why it is not clear right now, but it will be there. So this is the exiting nerve root on the ipsilateral side, and we are working in the Cambin's triangle. Just by tilting the the retractor system, we'll be going on the opposite side. The table tilt can be added here, and it will give further exposure on the contralateral side. This is just to demonstrate that with the tilt of the microscope how views changes. So this is the ligamentum flavum, the contralateral aspect of the dura.
Ashish, can we jump to the important step?
Yes. That's it, sir. This is basically the pre-op and post-op video of the same patient. Thank you.
That's an amazing video. It's good to see patient recover neurologically. So we are coming to the last video from Dr. Mukul Anand. By the time he shares screen, Rakesh bhai, any tips on tube docking? Any challenges? Rakesh bhai, are you there?
Yeah. So
Mukul, can you share your screen in the meantime, please?
Becoming a modern in waste as well as quite nephrotic and that's sulfuric acids. So those patients were to become difficult. So you have to take Gabapin and at that time whenever sulfuric and narrow medical, then a smaller tube we preferred for water or X tube.
Okay. So I think we'll go directly to the last video of the session. Dr. Mukul, over to you. Dr. Mukul? You are not audible.
He needs to unmute.
Mukul, unmute.
You need to unmute, Dr. Mukul.
Sir, am I audible now?
Yes, yes. Please go ahead.
Oh, okay, sir. So I'll be demonstrating the steps of a arthrospine duocum UB assisted ULBD. So the concept of ULBD was initially a unilateral laminectomy to perform a bilateral decompression. But with the advent of microscope and endoscope coming into the picture, now it's become more of a unilateral laminotomy. So it is basically an MIS approach. You can either do it, utilize it, perform it using a microscope, or a dry endoscopic technique, or a wet endoscopic technique. So to demonstrate the case in point, it was a 44-year-old male. He had a 3 months on-off duration with increased symptomatology since the past 1 month. He had complaints of low backache with the left-sided radiation. His sciatic nerve stress tests were positive, and he was unable to heel walk. His MRI picture was basically the area of interest was L4-5. It was a hugely up-migrated disc. And we can see on the sections that it was mostly on the left side. He had left side symptomatology, but there was also some material lying on the right side. So the diagnosis of a PIVD L4-5 up migrated to the left side partial foot drop was made. The plan was to approach from the symptomatic side, retrieve the fragment, and perform a ULBD to check both sides. So the theater setup was we perform our endoscopies under spinal anesthesia. The patient is laid prone on bolsters with a neutral lordosis, and a C-arm shot is taken by passing an 18-gauge spinal needle, keeping it in line with the target disc level. Something about the arthrospine duo assembly, I would like to acknowledge Dr. Kaushal for pioneering and innovating this technique. So this is the arthrospine tube, and initial dilators, 5 millimeters and 10 millimeter dilators, they are used initially to clear the soft tissues. These are the working insert. The 3-hole insert is used in dry mode, and the 2-hole insert is used for a wet mode. And this is the nerve root retractor, which is passed from outside the tube to retract the traversing root. So 10 millimeters incision is given, usually 5 to 10 millimeters paramedian on the symptomatic side, and with an 11 number stab knife to incise the skin and the fascia, and we perform blunt dissection up to the bone and the interlaminar window, and do serial dilation with the 5 and 10 millimeter dilators, and then the arthrospine tube is slit over the target interlaminar window, and again a lateral image is taken to confirm that our tube is docked at the right position. And this is the video of the technique. 12 o'clock is midline, 3 o'clock is towards the caudal end, 6 o'clock is towards the facet side, and 9 o'clock is towards the head end of the patient. So initially, this is the dry mode. I'm putting in a patty to expose my lamina of the L4. This is the L4-5 target level. Then I initially start the burring at the base of the spinolaminar junction. Mind you, right now we are working in a dry mode. I'm only burring the outer cortex. I'm trying to preserve the deeper cortex. Initial burring is done at the spinolaminar junction. Then I'm using a 45-degree 3 mm Kerrison to bite the deeper cortex to expose the underlying ligamentum flavum. And the proximal bone work is done till the ligamentum flavum is detached proximally. Then I'm using the burr to burr the base of the spinous process to create space to go on to the contralateral side also. After I've detached the ligamentum flavum, I'm trying to reflect it distally by using this blunt nerve hook probe. That's the glimpse of the dura below. I'm trying to put in a patty to create a safe working space and create a cleavage between the ligamentum flavum and the dura. Now I'm using a 90-degree 3 mm Kerrison to remove this flavum on my ipsilateral side. This is the left side. I'm trying to use a blunt tip probe to dislocate that fragment, but it is still too tight. So again, I'm trying, so the next step would be to burr more proximally to create more working space for me, proximally and laterally. Now I have zoomed in, and that is the fragment which is trying to peep out. Now I'm using a disc forceps to retrieve that fragment. It was quite a big chunk, and I was hoping to retrieve it in toto. and it was quite a big chunk that it was even not coming in through the main outer tube assembly. So I had to remove the entire assembly to get this piece out. This was like I had to remove the entire assembly also. And that was the huge piece which came out in one piece. And now I had switched over to saline mode. For that, you just need to change the working insert. Now the scope is inside and we are using fluid to visualize. This is the ipsilateral side, the traversing route, the nerve root retractor is, and this is this central decompression, which was already done in the dry mode. Now I'm placing a patty between the dura and the opposite side flavum to create a space. Now detaching the contralateral flavum bluntly with the Penfield elevator and using a 45-degree Kerrison to remove the opposite side ligamentum flavum. Right now we are all performing all this through the uniportal tube system. We are not switched over to UB. So this is a switching stick technique for UB. This can minimize our triangulation method also. I remove the tube, I place my scope through the tube channel, and now I'm looking at the proximal laminotomy, and I've nicked created a skin and a facial incision and pass a switching stick over that. And through that switching stick, I will now put my scope in the proximal portal, and now I'm working through the distal portal. And this is my UB retractor coming from the distal portal, opposite side disc. That's the opposite side disc. I'm probing the annulus to see if, and it's quite stable, so I didn't perform any annulotomy on the right side. And then I did a contralateral flavectomy to decompress the recess on the opposite side. And this was the final completed picture of ULBD. And this was the technique. There's a narrow field of vision. The instruments have to pass through the scope channel. They're very fine instruments, so there's chance of repeat breakage. There can be fusion can be performed, but then you can debate between the use of an expandable cage and adding to the cost. With the unilateral biportal endoscopy, there are problems of getting oriented initially, learning triangulation, and initially more radiation exposure while trying to triangulate. So with this switching stick technique of UB, initially I've docked my tube like this in line with the target disc level. Once I've done with my uniportal work, I remove the tube, I pass my scope, turn on the fluid channel through the same tube portal, tilt the camera towards my proximal intact lamina. And after that, I basically use an 11 number stab knife to nick my skin and fascia, and then pass a switching stick under vision of my camera. And then over that, I thread my scope sheath, and then the proximal portal, it starts working as a camera portal, and the initial tube portal, it starts working as a working portal. So I switched to UB, minimizing my triangulation risk and also reducing my radiation exposure levels. So what I feel is that this duo and UB assisted ULBD, it's an amalgamation of the wet and the dry technique. The eye is totally virtually inside. It affords us an enhanced visualization, less chances of neural injury. But surely there is a learning curve. There are issues getting oriented with the orientation. There is a risk of scope tip damage, and there is a risk of thermal injury and fluid associated risks while working in the saline environment. Thank you very much.
Thank you, Mukul, for an excellent demonstration. Now, actually, one Niraj is being arm twisted by another Niraj to draw the curtain down. But before we do so, the stage is set for our mighty emperor, Dr. Rajkumar Deshpande, to come and close the session. Dr. Rajkumar, sir, please hail Dr. Deshpande.
Thank you everybody. Thank you, Niraj. It's been a wonderful day and Sunday in the morning. All the young Turks have really performed phenomenally. I'm so happy and pleased to listen to all of you guys. Ketan, Rakesh, of course, Arvind is an old Turk. He cannot be considered a new Turk, a young Turk. Monu did beautifully well. I mean, Mukul finished off very nicely. And all the other guys, Tomar, I'm so pleased and happy. I should thank Arvind for thinking about this concept of a young Turk coming and presenting. I'm truly blessed to see such beautiful work. I wish I was a young Turk now. I could do some presentations. It's awesome. Thank you so much, guys. You have made me feel very good on Sunday. And as usual, Arvind, I love to see you again with your work sometime. It's always great to see you guys.
So we still consider you young. And
specifically after minimal invasive haircut.
Yeah. And
so I had a long hair last time.
Even younger.
I had a long hair last week, and I was being told that I'm an old tata and all that, so I decided to make myself slightly different. So anyway, it had been a long day in the morning for us on Sunday, and I think it's nice to have you all guys doing this wonderful session. I just wanted to close this day's work with the announcement that next year, hopefully there will be a better year than the COVID-19 year. We'll have 2 conferences in April and possibly October, November time. The April session is a surgical symposium, minimally invasive surgical symposium. It will be for a day at this point in time. And we want to do all the young Turks to share their wonderful video work. So get your cases ready, get your case discussions ready, get your presentations ready. Oh, Ranjit, you're back. Very good. You just signed off and you're coming back again. Thank you so much. So I wanted everybody to get their act ready, and we will send out by January. Early January, we'll get you the details of the meeting, how we are going to organize, and hopefully we'll have a great year next year. So thank you very much. Arvind, you want to add something? Please go ahead.
Yeah. Again, so to become members of MISSAB, I would request you to either contact me directly or go to the website and you'll get all the details. Best is to contact me. I will connect you with the secretary. I'm there on the MISSAB WhatsApp group. Most of you have my email address, or other ways to go on the website. Thank you so much.
So I think we will close this session, and before we do that, we need to thank Dr. Niraj Bidlani.
Before that, please, my one last Niraj, thank you so much. Thank you so much for hosting this.
Niraj,
which Niraj? Which Niraj?
Both Niraj.
Niraj Bidlani.
Both Nirajas.
I think both Nirajas, Niraj Square. Of course.
No, I think it goes to Bidlani.
Bidlani is awesome in, doing everything. But this young Niraj, my good friend, Niraj Vasavada, thank you so much.
Thank you, sir. Thank you, sir.
Thanks, Niraj, for holding the fort and doing a...
Yes. Ortho TV and Dr. Niraj, thank you so much.
Again, thank I thank Intas and Ortho TV for this phenomenal streaming of the session today and the sponsorship. Now, the next MISSAB webinar will be on 10th January, which is happens to be the second Sunday of January 2021. Thank you.
Right.
Have wish you a
happy New Year.
Thank you all. Thank you.
Happy New Year
in advance.
Thank you.
Thank you, Niraj.
Thank you. Bye-bye.
Thank you. Bye-bye.